review for USMLE Step 1. The topic for today is male reproductive pathology. We'll begin this area by looking at the various congenital abnormalities that can affect the male reproductive system. Hypospadias refers to a condition where there is malformation of the urethral groove and urethral canal, resulting in an abnormal opening on the ventral surface of the penis. The problem here is that these urethral defects can lead to urinary tract obstruction and an increased risk for infection. Epispadias refers to a similar condition, except here the malformation of the urethral groove and canal leads to an abnormal opening on the dorsal surface of the penis. This is less common than hypospadias, but again, the resulting malformation can lead to urinary tract obstruction and possible infection. Phimosis refers to a condition where the orifice of the foreskin is too small to permit normal retraction. Hence, one is going to worry about this condition in non-circumcised males. Can result from abnormal development, but also from scarring due to repeated infections. Paraphimosis refers to a condition where a phimotic foreskin has been forcibly retracted over the glans penis, resulting in constriction and swelling when the foreskin cannot be brought back over the head. Various infections that can lead to phimosis and paraphimosis are things such as balanitis, where there is infection of the glands and foreskin. Rare in circumcised males, you can see it more often, not surprisingly, in non-circumcised males. The infectious agents tend to be things such as Candida albicans, anaerobic bacteria. Gardnerella can also play a role here as well, and not surprisingly, it is often associated with poor hygiene. Syphilis is another particular lesion that one can see in this area due to infection with Treponema palladium. The classic lesion here is the chancre, an elevated, painless ulcer that resolves after 4 weeks, but in which the patient, if not treated, will progress on to secondary and tertiary syphilis. Other infections that can affect the male reproductive system are gonorrhea and intracellular gram-negative diplococci. This leads to the classic picture of an acute purulent urethritis with the patient complaining of dysuria and frequency. This, if not treated, can extend to the prostate, seminal vesicles, and epididymis, but usually not to the testes, a factor which may clinically help you distinguish this infection from others that tend, for whatever reason, to preferentially affect the testes. Chlamydia is a form of non-gonococcal urethritis that can present very similarly, again with dysuria and some sort of acute purulent urethritis, although the discharge here tends to be more watery and clear compared to the copious white secretion that one sees with gonococcal urethritis. In general, one will not find bacteria in chlamydia urethritis in the urethral discharge, and this, again, if untreated, can go on to the development of an epididymitis. Benign tumors that can affect the male reproductive system include things such as condyloma acuminatum or the venereal wart. Caused by human papillomavirus types 6 and 11, it is characterized by the classic pedunculated red papillary excrescences that can cover the penis and other areas. When one looks at these tumors histologically, what one sees are the classic branching villous papillary connective tissue surrounded by an exuberant, stratified, thickened hyperplastic squamous epithelium. What one also sees within the squamous epithelium are the classic prickle cells, the clear vacuolization of the upper layers of the epithelium, seen here in this histologic slide, with the clear cells with slightly eccentric nuclei representing cells infected with HPV. Bowen's disease, or carcinoma in situ, is a premalignant condition preceding squamous cell carcinoma of the penis. One generally sees this in patients 35 years of age or older. Generally involves the shaft of the penis or scrotum. What one sees are shallow, thickened, often gray white plaques that have a region of shallow ulceration and crusting. They can be confused with things such as the chancre of syphilis. When one biopsies these lesions, what you see is epidermal thickening with numerous mitoses and nuclear and cellular atypia, represented as dysplastic cells, often with large hyperchromatic nuclei, and the lack of orderly maturation that one would expect to see from the base of the squamous epithelium to the upper external layers of the epithelium. However, here the dermal-epidermal border is still sharply delineated by an intact basement membrane, hence no invasive cancer has yet developed. This may, however, in a minority of the cases, approximately 10%, invade and develop into a superficial spreading squamous carcinoma. Squamous cell carcinoma is uncommon in the United States, affecting less than 1% of males, and the risk is lowered with circumcision. Interestingly, HPV type 16, 18, 31, and 33, previously associated with invasive squamous cell carcinoma of the female reproductive system, also appear to be associated with male squamous cell carcinoma of the reproductive system. There is also increased risk with cigarette smoking, and usually this tumor will appear in affected males somewhere between the ages of 40 and 70. The clinical features are a slowly growing, locally metastasizing lesion, which likes to go to the inguinal and iliac lymph nodes. This tumor shows the necessity to be very frank and upfront with your patients in questioning them both in your history and doing the physical exam, as if this tumor is caught early before it metastasizes to the inguinal and iliac lymph nodes. There's a 66% 5-year survival rate, which drops to less than half that once the tumor has metastasized. Now, in terms of conditions that can affect the testes and epididymis, again, we'll deal first with congenital abnormalities. Cryptorchidism is a condition where one or both testes are undescended. It affects approximately 1% of all 1-year-old males. It is due to the complete or incomplete failure of the intra-abdominal testes to descend down into the scrotal sac. Generally, it will be unilateral in most cases. The great risk here is an increased risk for developing germ cell tumors, even if the undescended testes is brought down within the scrotal sac. This risk is increased both in the undescended and the appropriately descended testes. Thus, if a patient has had cryptorchidism, even if it has been surgically corrected, one must be aware of their increased risk for a germ cell tumor later in life. If this condition is untreated, it can also result in atrophy and sterility. Other causes of atrophy within the testes, in addition to cryptorchidism, this can be the end stage of various inflammatory diseases, such as if we have the spread of conditions such as chlamydia or gonorrhea, or conditions such as tuberculosis. Also, as one ages, there is often progressive atherosclerotic narrowing of the blood supply, which also leads to atrophy of the testes. Conditions that affect the endocrine axis, such as hypopituitarism, will also affect the development of the testes. Patients who undergo generalized malnutrition or have, for any reason, an obstruction of the outflow of semen or receive radiation in this area, perhaps for treatment of prostatic cancer, can also undergo testicular atrophy. And finally, not surprisingly, if for some reason the patient is exposed to female sex hormones, they can also undergo testicular atrophy. This is an example of the end result from any of the causes listed above. What one sees is thickening of the basement membrane around the tubules, where one sees within those tubules Sertoli cells, but note the essentially empty lumens with no spermatogenesis occurring. Inflammation of the testes is referred to as orchitis. This is generally due to a bacterial cause of some type. Viral causes generally one sees secondary to the development of mumps. If this is bilateral, not surprisingly, the end result can be sterility. Epididymitis, or infection of the epididymis, is generally more common than orchitis, and the organisms that one is going to think about here are going to be ones that we've mentioned earlier, things such as Neisseria gonorrhea or chlamydia. You can also see it with things such as E. coli, and this is also a place where Mycobacterium tuberculare can play. This is an example of gonococcal epididymitis. Here, the epididymis has been replaced by an abscess that represents the left-hand part of the slide. Normal testes is seen on the right. Granulomatous, or autoimmune orchitis, is a rare cause of generally unilateral testicular enlargement. How this will present clinically is usually a patient will present with a moderately tender testicular mass with the condition occurring suddenly and sometimes with an accompanying fever. As the name implies, you would not be surprised histologically to see granulomas within the spermatic tubules and also within the intratubular connective tissue. Other causes of inflammation within the testes can be secondary to things such as mumps. As you're, I'm sure, aware, a viral infection that usually affects school-age children, orchitis can develop and has been reported in anywhere from 20 to 30% of male patients. This orchitis generally develops 1 week after the inflammation begins to affect the parotid glands. Tuberculosis is interesting in that it begins in the epididymis and then will spread to the testes and presents, as it does elsewhere in the body, with caseating granulomas. Syphilis, unlike what we have talked about with things such as tuberculosis, Neisseria, and chlamydia, likes to begin in the testes first, rather than beginning elsewhere within the male reproductive system and spreading to the testes. Here what sees are the gummas or diffuse interstitial inflammation with surrounding edema. Now, the testes are also prone to various architectural distortions, among these being various vascular abnormalities. Perhaps the most concerning is torsion, where there's twisting the spermatic cord around the arterial and venous supply of the testes. As I'm sure you remember, the arteries have very thick muscular walls, and so are less prone to being obstructed by the twisting of the spermatic cord, compared to the relatively thin walls of the venous supply. Thus, what one has is blood continuing to be pumped into the testes, while blood cannot be pumped out. This then ranges, in terms of its clinical presentation, from intense congestion to widespread extravasation of blood out of the blood vessels into the interstitial tissues of the testes and epididymis. This can lead to hemorrhagic infarction of the testes, later on the testes developing into a large sac of soft necrotic and hemorrhagic tissue. As one sees in this picture that follows, where a area of torsion was left untreated, the testes enlarged and eventually underwent hemorrhagic necrosis. That ends the first half of this Falcon lecture for Pathology Review for USMLE Step 1 on the male reproductive system.